Hello everyone, welcome to Radiology Case Review Series. In this video, we are going to look at images of an elderly male patient who presented to emergency department with abdominal pain, nausea and vomiting. I'm going to start initially with the CT examination performed many years before the current admission. On the CT performed many years ago, you can see a gallstone in a non-distended gallbladder. Due to clinical concern for acute abdominal pathology, emergency department team ordered a CT examination. I don't have an abdominal radiograph, so I'm just going to show you the localizer images from the current CT examination. On the localizer images, we can see dilated small bowel loops, highly concerning for small bowel obstruction. As I zoom in the right upper quadrant region, you can see pneumobilia, and as I window in the region of right lower quadrant, you can see a vague calcific density in the right lower quadrant. On the axial CT images, as you scroll down, you can see stomach is massively distended, and we can see air within the gallbladder which is decompressed with mild wall thickening, and you can see a fistulous tract between the duodenum to the gallbladder. And as I scroll down further, you can see dilated small bowel loops consistent with small bowel obstruction, and a calcified lesion is seen within the lumen of terminal ileum, which corresponds to the gallstone which we saw on the old CT examination. You can see similar findings on the coronal reformats. We can see the fistulous tract between the gallbladder to the duodenum. We can see the dilated small bowel loops, and we can see the calcified gallstone in the terminal ileum. This is the ileocecal valve, so the gallstone is stuck in the region of the terminal ileum. Imaging appearances are consistent with gallstone ileus. In terms of imaging appearances, historically we used to do radiographs. Classically, the findings are described by Rigler's triad. As we saw in our patient, we can see the ectopic gallstone in the intestine, air in the biliary tree and gallbladder, and small bowel obstruction. But things have moved quite a bit. We don't do radiographs for acute abdomen. So on the CT examination, we can see similar findings corresponding to Rigler's triad. Additionally, the exact location of ectopic gallstone is much better delineated on CT examination. Also, it is important to realize that there can be multiple stones at different locations, so it's important to interrogate the entire bowel for any additional stones to prevent future bowel obstruction. Also, the site of obstruction is well delineated on CT examination. Most common site of obstruction is terminal ileum. Other sites of obstruction could be proximal ileum, sometimes in the rectosigmoid region. Rarely the stone can get impacted in the duodenum, which goes by the eponym of Boverat syndrome. And as we saw in our patient, CT examination demonstrates the biliary enteric fistula. I hope you found this case of gallstone ileus to be interesting and informative. Thanks for your attention.